Anomalous left main occlusion following mitral valve replacement. Per literature review, there are several documented reports of anomalous coronary artery occlusion after aortic or mitral valve replacement, but no previously documented report of anomalous left main occlusion was identified after mitral valve replacement. With an incidence of 1 to 2% in all patients undergoing cardiac catheterization, anomalous origin of coronary arteries is usually an incidental finding. Most frequently, the left circumflex artery originates from the right sinus of Valsalva. The presence of anomalous coronary arteries in a patient undergoing valve replacement confers an increased risk of morbidity and mortality due to subtle postoperative changes which can mimic normal postoperative findings, including chest pain and hemodynamic fluctuations. In this case report, an anomalous left main coronary artery occlusion occurred after mitral valve replacement, and this was identified after the patient developed low-grade shock and multi-organ injury. A 53-year-old female with past medical history significant for cryptogenic stroke approximately 10 years ago presented for recurrent admissions for pneumonia with shortness of breath and cough. She was found to have severe mitral regurgitation and heart failure with preserved ejection fraction. Left heart catheterization with coronary angiography demonstrated a single coronary artery origin from the right with retroaortic posterior course identified on the coronary CT with anomalous left main coronary artery. TEE demonstrated thickening and restriction of the posterior mitral valve leaflet with posteriorly directed severe mitral regurgitation with Coanda effect. The patient underwent mitral valve replacement using a 29 mm Carpentier-Edwards Magna-Ease pericardial mitral valve bioprosthesis, left-sided Cox-Maze with cryoablation, and a 40 mm AtriClip placement due to history of cryptogenic stroke. Post-procedure, she developed mild hypotension requiring vasopressors with low cardiac output and AV dissociation. Extubation was on postoperative day 0. She subsequently developed acute kidney injury, transaminitis, metabolic acidosis on postoperative days 3 and 4 with inferolateral ST depressions on ECG suggestive of ischemia. Repeat echocardiogram demonstrated a newly reduced left ventricular ejection fraction of 20 to 30%. Urgent coronary angiography demonstrated an occluded left main. Percutaneous intervention with drug-eluting stent was performed. In a Texas Heart Institute retrospective case review series from 2014 to 2016, 8 patients with anomalous coronary arteries underwent surgical or transcatheter aortic valve replacement. 2 patients prophylactically had coronary artery interventions to prevent artery occlusion. 2 of the 8 patients had perioperative myocardial infarctions caused by coronary compression. These were surgical patients. Another case report demonstrated postoperative non-ST segment elevation myocardial infarction after both aortic and mitral valve replacements, causing coronary artery compression of the anomalous left circumflex. Despite preoperative identification and knowledge of anomalous coronary artery anatomy, sometimes compression or occlusion of these anomalous vessels is unavoidable and unanticipated. In conclusion, intraoperative and postoperative monitoring of patients undergoing valve replacement in the setting of anomalous coronary arteries necessitates a high clinical index of suspicion for coronary compression and/or occlusion. Prophylactically, coronary unroofing, bypass, and mild undersizing of the prosthetic valve should be considered. Additionally, performing a hybrid procedure to reevaluate coronary angiography post-procedure may identify subtotal occlusions and prevent morbidity and mortality associated in these complex patients.